Hello and welcome back, everybody. Thank you for joining us this morning, and we're about to begin our second session. It's my pleasure to introduce Charlotte Holmes, who's a trainee in the Northeast, and Charlotte's going to share a presentation about her thoughts around how her SD1 application experience and her top tips and advice for you. So we'll start with a presentation and then there'll be plenty of opportunity to ask questions. So enjoy the presentation and we'll see each other shortly.
Hello, my name is Charlotte Holmes. I'm a cardiothoracic registrar from the North East Deanery. I've been asked to speak to you today about why I chose cardiothoracic surgery and how to apply for ST1 training. I'm going to talk about why I chose the specialty, what our training program looks like, how and when to apply, how the application process works, how you can make yourself as competitive as possible, and just some general handy tips and advice. Cardiothoracics is a vast specialty, and around ST4-5, you need to declare whether it's cardiac or thoracic that you're going to specialise in. Cardiac involves adult general, such as coronary artery bypass grafts, aortic valve replacement, mitral valve repair or replacement. There are minimal invasive techniques to learn, particularly for mitral valve replacement. There's aortic surgery, either as an emergency for type A dissection or electively for aneurysms. Transplant largely falls under cardiac surgeons, although there are some thoracic surgeons doing lung transplants. And there's pediatric and adult congenital surgery, which is a whole talk in itself. But generally, you need to do your general adult training and then do fellowships or specialty placements in pediatric and congenital if you have that at your unit. Thoracic surgery, a larger part of what we do is lung cancer resections, either via open surgery or thoracoscopic VATs. There's minimal invasive techniques such as robotic and single port VATs. We operate in the airway using bronchoscopes, using laser, stenting, balloons, and have sometimes do biopsies, either for benign obstructing pathologies or tumours. Trauma largely falls under thoracic surgery at most centres, although cardiac surgeons and some. There's chest wall surgery, and that's a picture of a NUSBAR and X-ray for pectus excavatum. We do washouts and debridements for empyemas. And we do bulectomies, as you can see there, stapling of a bulla, either as an emergency for pneumothoraxes or lung volume reduction surgery to remove non-functioning lung to help improve lung function in people with COPD and emphysema. Why train in cardiothoracic surgery? It's life-changing, life-saving operations that we do. You can see the impact immediately, and 4 weeks in clinic, patients are itching to get back to their normal lifestyle. It's therefore very rewarding to see that change almost instantly. It's a wide variety of pathologies that you see, so there's always subspecialties to interest you. It's a highly technical, highly specialised craft, ranging from putting someone on bypass and intricately stitching in a vein graft for conduit for coronary artery bypass grafting, to learning robotic skills in thoracic. It's a multidisciplinary approach to most things of what we do. Therefore, you learn from cardiologists, respiratory doctors, anaesthetists, oncologists, radiologists, microbiologists. You're forever learning. And therefore, it's overall very rewarding. What does the training program look like? So as of August 2021, it's going to be a 7-year program. There's 2 points of entry, either completing core surgical training years 1 and 2, and then applying for ST3 entry, or applying for ST1 run-through training. It's worth noting that if you don't get in first time round and you take up your core surgical training post, you can apply to leave that post for the following year to obtain an ST1 post. There is more emphasis on ST1 entry, therefore there's more jobs at ST1, and on the ST3 matrix, the amount you need to achieve to be deemed appointable is therefore greater, especially operative skills. Therefore, it's more competitive at ST3. At ST1 entry, you will have your interview, and if you complete ST2 ALCP and have your MRCS exam, which you would need at the end of core surgical training U2, you would then progress to ST3. At the end of the training, we tend to do fellowships to subspecialise in those areas I talked about, paediatrics, transplant, and then apply for consultant posts. There are academic pathways for those who are interested in becoming academic surgeons, where you work part-time research or education and part-time clinical. There are academic clinical fellowships which you can apply for, which aren't in every deanery and not advertised at the same time as the ST1 posts, where you have a significant amount of time for research as well as clinical in the first 3 years, with the aim to obtain a research qualification, and with the hopes of taking time out to do a PhD during your training. It is possible to do a PhD at any point in your training, even if you don't have an academic clinical fellowship, as long as you have a postgraduate qualification and you have agreed with your educational supervisor and training program director to take time out of training. How does the application process work? It's via national selection. You apply via Oriel to the Wessex Deanery, and their website has a wealth of information for you. That's where all the person specifications, what kind of person they're looking for, and the scoring matrix, which I'm going on to show you, is all held there, and it's a wealth of information. The application dates, interview structure and scoring, that's all on that website. So have a look. It's Cardiothoracic, ST1, ST3, Wessex Deanery, and it'll come up. Applications tend to open in November. It's via Oriel. This is sort of what the Oriel application looks like. As you can see, it's quite complicated, which I'll come on to later. 3 invigilators will score your application using the matrix out of 40, given an overall of 120 possible marks, and they're roughly looking for a score of around 64 when I applied. Interviews open in February. There's a communication station, 6 structured questions with topics such as clinical scenarios, ethics, research and audits, teaching. There's then 3 clinical skill stations: fact skills, knot tying, and excision of a lesion and wound closure. You will then be ranked against your peers at interview, and they open the preferencing window for you to rank the jobs. It's really important to read the preferencing document they send you at this point. It lists all the deaneries, where the jobs are and what they offer to you in ways of training and subspecialties of their units. Not every unit has transplant or pediatric, so if that's what you're interested in, you need to aim for those units. It tells you on there how much time you're going to get in cardiothoracics in the ST1, ST2 period, as it varies per deanery. Some people get 6 months. In our deanery, we were very lucky and got 14 months. So it really is dependent on where you are, and the other jobs that you'll need to do will also be listed in that document during that time. So have a look. Posts this year were few, ST1 or ST3, 10 jobs in total. It varies every year, so keep an eye on the Wessex Deanery website. It just depends on how many trainees they have in the system. But do not despair if you do not get in first time round. If you do a fellowship in a surgical specialty, cardiothoracics, and show evidence of career progression, or you take up your core surgical training post and then apply to remove, you actually get an extra point on that matrix, as you can see there. This is from the up-to-date matrix from the Wessex Deanery website, which is available to you. They will score you on your undergraduate academic career, with the most marks for exceptional career. Have you won any awards or prizes? Have you got honours with your degree? They will look at your undergraduate electives and attachments. To score 1 point, you need at least 2 weeks in cardiothoracic surgery elective. So therefore, if you come to the decision late, it doesn't matter as long as you have 2 weeks at least. But if you have more than that, you'll score 2 points. They will then look at your higher degrees. Have you done a master's with a research component in cardiothoracic surgery? That scores you 3 points. If you're working towards it and you haven't finished it, please put that in your application because you can get 2 points. BScs, BMed Science, other degrees will come in 1 point there. They will then look at diplomas and other qualifications such as leadership, education diplomas. If you have more than one, it counts for 2 points. One counts for a point. As you can see there in bold, the MRCS exam is no longer included in the scoring matrix, so do not panic if you don't have your Part A exam. You would definitely not expect it to have your Part B exam, as it requires clinical experience. So don't worry about those and focus on those. If you do have a job with more time that lends to revision, such as GP or psychiatry, then you can dedicate 3 months to revising for the exam. It's worth doing around the time of leaving medical school when the knowledge is fresh, but don't focus on it if you want to focus on other things or have too difficult jobs. Postgraduate research is scored, postgraduate prizes, and then postgraduate clinical courses. So if you do your ATLS courses, your start surgery courses, your basic surgical skills course, this will show a strong evidence of commitment to cardiothoracics and surgery. That'll get you 2 points. They will look at your presentations, and you score the most points for having a national oral presentation, such as SCTS Patrick McGee oral presentation, for example, but it doesn't have to be cardiothoracics. Any national oral presentation counts. So do bear that in mind if you come to cardiothoracics late. Anything counts. It doesn't matter if it's palliative care or GP, it counts. Publications are the same. You get more points if they're related to cardiothoracic surgery, but others do count. You get up to 3 points for having 3 or more first named author papers or book chapters relevant to cardiothoracic surgery. So surgery or cardiovascular disease, education, something related, 3 points. If you can have a single first named author paper, peer reviewed, that gets you 2 points, plus named author in other journals. So it's really important to have publications and start early. Case studies are slightly easier to publish. There are free journals to publish in. They will look at your clinical audit, up to 3 marks for having sustained commitment to audit. So that's your closed loop audit. So measuring your clinical practice, implementing a change, seeing if that's improved the change, that's a closed loop. Tweaking it a little and trying to close another cycle, again, that's sustained commitment. They then look at your organisation and leadership skills. Have you held a chairmanship, secretarial role or other leadership role in a national body or led a major expedition or project? That's 3 marks. But having a local or regional role gets you 2 points. And again, that doesn't have to be inside of medicine or even surgery. Then they will look at your practical and psychomotor skills. And again, this is outside of medicine, outside of surgery. Have you achieved a level in sport or arts or music or technology and design? It's up to 3 points. They then look at your teaching commitment. If you've developed a course nationally or a conference with teaching component, that would get you 3 points. If you have a regular teaching commitment, that gets you 2 points. They will then look at your surgical experience in this part of the application where you list the number of procedures you've done, and that's out of 3 marks. And then again, 3 marks is your personal statement, which is the overall impression of the application, and then 500 words at the end where you write anything extra that you haven't included elsewhere, and mentioned, why you want to do cardiothoracics and why you'd make a good cardiothoracic surgeon. My journey. So I knew I wanted to be a surgeon, and particularly cardiothoracic, since I was about 16, wanted to be a doctor since I was 13. So I sort of hit the ground running and joined the Cardiothoracic Surgical Society, and got my free affiliations to the Royal College of Surgeons, went on relevant courses, went to the SCTS conferences and applied for the Patrick McGee Medal competition. I joined the Peer Teaching Society. I joined the Star Surge Society, the national audit team in general surgery, and held a regional leadership position, which gave me named author publications. I rose to Surgical Society president, and we set up and ran a national conference. I chose to do a BMed Sci in 3rd year, which was cardiothoracic research, which gave me a publication and presentations. I did all my electives where I could in cardiothoracic surgery and where I couldn't in surgery. And I also did a 2-week elective at James Cook Hospital, which I was the first student to do that. And it's now been set up as a regular programme that runs throughout the year. You apply through RCS Edinburgh with an essay, and you can come and work with us for 3 weeks, and we take you through stenotomies and thoracotomies and how to work in cardiothoracic surgery. So it's worth coming. It gets you 2 points in that application. In foundation, I did audits and took up a leadership position as foundation rep, did my postgraduate surgical courses. I took up a 3-year part-time distance learning master's, doing my certificate in year 1, then the diploma in year 2, and completing my master's in year 3. I taught medical students regularly and kept up with the SCTS meetings. I wasn't successful in my application first time round, which I'm not ashamed to say. I didn't get help with it. I did it by myself. As you could see, it was very complicated. Wasn't sure what counted, wasn't sure what went where. Did it by myself and didn't score enough. And it wasn't because of my CV, as you can see here. It was because I didn't ask for help. So what did I do? I was committed to Cardiothoracics. So I took up a clinical and research fellowship, which was in spine surgery. I couldn't get a cardiothoracic fellowship. And this allowed me transferable skills, had my own operating list for training, had my own clinic. It made me more an independent practitioner, also allowed me publications, audits and presentations through my research, allowed me to finish my master's. I did some more courses, set up a junior doctor teaching program, and during my annual leave went on a Peru volunteer mission to do general surgery, actually, for people who couldn't afford it, to give back to my elective program that I went as a medical student. So breakdown scoring, what can you do? So academic work, have you got honours or distinctions, any awards or prizes? Have you entered any essay competitions through the Royal Colleges or societies? Try and make the most of your electives and your SSCs, try and do audits or case studies and present them, try and publish. Teaching, get involved early at the Peer Teaching Society, are there any teaching courses through the university? Do relevant courses as a medical student through the colleges and the associations of surgeons in training and SCTS. Are there any positions of responsibility on societies? And think about intercalation. Not everyone does so, but it can be very valuable. And find a mentor, someone who can help you with your application. Foundation, don't have to concentrate on your exams, but do your audits, do the surgical courses. You have a week of taster days in foundation to use them in cardiothoracics. Other positions of responsibility you can take, trust rep, rota rep, attend the conferences, try and present at these conferences. There's a number of cardiothoracic related and surgical conferences. And there's also the Edward Jenner Leadership Fellowship, which is free and part-time distanced. So make the most of your electives. Keep a logbook. elogbook.org is free. There's an app. Even if you've observed an operation, put that in there. If you've assisted, write what you've done. At every placement, print it off without the patient details. Get it signed by your supervising surgeon so that you're not looking back years later to try and get that validated. Join university societies, take up leadership positions. Affiliations to most of the Royal Colleges, of which there are 4, Edinburgh, England, Glasgow and Ireland, are free, and same for SCTS. So please get those affiliations, and then they'll advertise to you relevant courses which you should attend. Looped audits are important. You can start them at medical school, and again, it doesn't have to be cardiothoracic related as long as they're good clinical audits that make a difference. Think about your foundation jobs. Do you want to do a foundation job in cardiothoracics? Are you happy to move deanery for that? Because they're not in every deanery. I didn't have a foundation job in cardiothoracics, and I'm where I am today, and I caught up. I did feel that my counterparts who had F2 jobs in cardiothoracics might have been a bit more experienced, but everyone comes with varied experience and you can all catch up. So it's not necessarily important, but might be worth considering. Don't give up if you don't get in first time round. Consider taking your core surgical training post and then redoing the year if you get the ST1 post the following year, or have a look at fellowships. There are some national fellowships in cardiothoracics or other surgical specialties. Use this matrix that I showed you, score yourself, work out where you're weakest, work on that. Keep evidence for everything you do. If it's paper, scan it electronically. If it's electronic, print it off and keep it in 2 places as you go along so that you're not scrambling around 6 years later. And get that all-important mentor. I found a cardiothoracic consultant who'd been involved in recruitment via my BMed-Sci supervisor, who looked through my application, looked through my CV and really helped me cram it all in there. So then when I applied the second time round, I was successful because I've got enough points for interview. When it comes to interview, there are courses that are paid for or You could ask a supervisor to do a mock interview for you. It's better to practice your answers for the day. And there's also this useful book, and don't worry, I'm not getting any sponsorship deals for it. There are other books available, but this book here is what a lot of us use, and it's very useful for structuring your answers. Thank you for listening. Here's a picture of my Freeman family at the beach, my James Cook family at the lung cancer ball, and my home life is my boyfriend who's next to me in a bow tie and my dog there at the beach. You do have a life outside of surgery. Then my email address is there. I'm happy to be contacted if you need any more advice. Any questions?
Charlotte, for sharing your presentation with us. I think you are around, so it'd be good to see you on screen. Just to emphasize that Charlotte's shared a lot of information, and don't panic because a lot of it is on the Wessex Deanery website, so you can go there at your leisure. You don't need to be sort of taking screenshots or anything. And all the things, particularly about personal specifications, etc., are there, both for the application form and how the interviews will be conducted. They tend to be in normal times in Southampton. So lots of information on the website. And thank you, Charlotte, for sharing the way you sort of navigated the system, etc. So it's been really helpful. So I'm going to try and moderate the questions and. What is considered, a question from Naeem saying, what's considered to be surgical experience? Is it theatre time only or time spent in the department? Well, personally, I think it's both, really, because theatre, as being a surgeon, is not just about being in theatre. The most important component is. But Charlotte, do you want to say anything about that? Or... And I think that question is, we can't hear you, Charlotte, but while you're fixing that, I think the question has also added, because they're asking about the 18-month time limit, and you're right. It is, I think that probably means specific rotations or slots that you do. That would be the 18 months. If you popped in for 2 weeks taster or etc., that's not going to, or got experience at the weekend, that wouldn't be held against you. That would only strengthen things, I think. So... did you want to add anything, Charlotte?
Can you hear me now?
Yes.
Yes, no, I agree. There is, your logbook experience, but it's also commitment to specialty, and becoming a surgeon is not just about operating. It's about, being a good clinician, putting patients first, and knowledge of the specialty. So there's a lot there. And yes, you need under 18 months experience for ST1 application as it stands at the moment.
Okay, thanks. And somebody's asked, Anonymous has asked, what about people who don't know they want to do cardiothoracic surgery until the final year? Well, I don't think that's an issue. It's a problem because a lot of the, some of the points come specifically for cardiothoracics. Obviously, you may not have them, but a lot of them come from interest in the surgical field, in the specialty. So I think there is time to make up for that. And so if you decide in your final year that's the job for you because you've been exposed to it, you still have plenty of time during F1, F2 years to add to your portfolio for things, and even attending things like this student engagement day, or maybe getting a national role or a regional role, a local thing at your own hospital. All these things will, sort of count. So no need to sort of be too concerned, because people have different journeys into cardiothoracic. Some people are obsessed with it from an early age, and some people stumble on it and then decide that it's for them. So the question about clinical observership, is that counted in the 18 months? I wouldn't have thought so, but I think that if there's any specific questions, it's always worth contacting the deanery and the Wessex Deanery for that. But I would have thought not, because it's not a specific thing. But please do double check that. So lots of questions on this. So Charlotte, so get prepared. So is it true that there's a big bottleneck at CCT and lots of registrars? Well, I don't know the specific numbers, but I think we alluded to it earlier. In the earlier presentation, workforce planning is always difficult, knowing what's going to happen in 7-8 years after you appoint a group or a cohort of people. And I do know that I think the numbers, there's a good thing in the RCS Bulletin, Royal College of Surgeons Bulletin, on training written by the SAC, so that will be worth reading. And I think the way people try and monitor, sort of approach this is having perhaps, if you can see that something, a bottleneck is coming up, then reduce the NTN number, the training numbers. So it's not a precise science. So you may find yourself, you know, in 8 years' time, not necessarily having enough jobs to apply for, but that doesn't mean there isn't a role for you. So a question about how to get a research fellow job, and can you recap a few tips from scratch? Okay. Now I'm thinking, I guess look out for the jobs, but also look out for opportunities, because many hospitals, and you don't have to be in an academic unit, you know, or in a big teaching hospital, but there's often projects going on at the local university. But I think it's just a matter of finding people already involved and then trying to get yourself involved in whatever is going on in the department at the beginning, you know, where you are. You're not going to be able to, I suggest you're not going to be able to sort of spin up a whole project and set up a PhD, and if you're very, very early on in your training, but you can join people and do parts of a project, then hopefully get recognition for that. So, okay, so I think that's, again, another question about publications, and I think it's really hard. I don't know if, Charlotte, you've got any tips on how you did it, but I think from my perspective, some of the, not easier, but you might want to do an interesting case. Start with a case report, something that you've seen in theatre or outside theatre, and it doesn't have to be in cardiothoracics. I think that's the point I really want to emphasise. A lot of these things translate across other areas. So case reports to start off with, maybe a literature review. I mean, and when you're doing audits, etc., often things that bug people every day. Maybe in the ward you notice when you're doing a ward rounds. So don't all do this, because there'll be hundreds of the same project. But, you know, maybe people aren't. You go around and you notice people aren't wearing TED stockings. Do a little project on that. Sort of spend a week seeing who's got TED stockings, why not, etc. Make a change, and I'm sort of giving you a whole project to do now. So instigate change with the beginning, and then re-audit it the next week. That's not research, that's audit. But again, all these things make, and then people know that you're interested. And the one big thing is finish what you're doing, because there's no point having 10 projects in the go. It is really disheartening when you're reviewing CVs for people and they've got 10 things and it says ongoing. That doesn't mean to say you generally don't have a project ongoing, but if you have 12 ongoing, then in ongoing for a couple of years, I'd suggest you're not really doing them very well. So anyway, I've got that off my chest. Okay. Somebody else has asked about, how can we find out about voluntary mission in Peru? I'm not quite sure specifically.
That's for me. So I went with Ishi Global. There are other charities that go, and they're an American, a Canadian company based in America, actually, who I met through my connection. So I did my medical school elective in Peru, ran by a British gentleman, and he introduced me to them as I wanted to come back. So I applied to go with them via the charity. There are other organisations out there. But I would say Ishi Global are very ethical if you are looking to go there specifically.
Okay, thank you, Charlotte. And got a question about, where has it gone? It's about leadership and presentations and how you can do them in these difficult times when we're not going to meetings, etc. I think one of the, as well as cardiothoracic specific events, I think there's many events that I think I would really encourage you all to look at ASIT. I'm sure many of you have heard of ASIT, the Association of Surgeons in Training. They have lots of opportunities in terms of presentation, local events, prizes, and also the opportunity to get involved, which I think, Charlotte, you mentioned. They have various collaboratives so that you can actually be part of major projects. So look at things that might be simple, but numbers regionally are, you know, in one hospital alone are low, so you can actually get your name on publications.
Yeah, we get published. Yeah.
Research collaborative. So look up ASIT. They have lots of opportunities. become an affiliate of a college. I'm a council member of the Royal College of Surgeons of England, but we have other colleges, Edinburgh, Glasgow, and also the Irish College, if you're there. So all of these have sessions for medical students and affiliates. It's usually 10, 15, 20 pounds a year, and you can get involved in sort of competitions, etc. they have. So there's lots of opportunities. And I think it really is to show you that you're engaging. You are trying to learn, you're trying to find out about it, and that just sort of sets your stall up really as to the fact that you are really interested in it. So how are we doing for time? 11:30. I think, are we bang on time, I think, for the next session? Is that right? My behind the scenes team. So I think we are about to join. Is it 11:30? I'm talking to myself now, because nobody's joining me. So the next session is due to start at 11:45. No, we've got a few more minutes. So Charlotte, did you want to say something?
So when it comes to looking for fellowships, I think there was a question about fellowships. If you're in a deanery with a cardiothoracic department, look for someone who's interested in research, try and get involved. That way, they might be advertised nationally. For research, consider doing an intercalated degree, a BMed Sci with a research component. That's an easier way at medical school to get into a research career, which might be publishable and presentable. And again, it doesn't have to be in cardiothoracic surgery. It's beneficial as it is, but it doesn't have to be. There's quite a lot on that matrix that's transferable to things outside of medicine and other specialties in medicine that you'll score points for. And that this is how you sort of find your connections and your networking. A lot of it is networking and making connections. So I'd advise you get in touch with your local department. I'm happy to be contacted, but there's lots of other trainees who are happy for students to be involved in their research. Absolutely.
And I think on that point, Charlotte, the networking and I guess really mentorship, you mentioned that you found somebody, and not every medical student will work in an area where they have a local cardiothoracic department. And I think that's why we at NSYNC and my student colleagues who are running the committee, we're all really keen that we make this available to everybody, not the lucky few or the chosen few who happen to be in the right place at the right time. And that's why we're really excited about our mentorship program, not just the Inspiring School Children, but actually making it available for everybody at any medical school across the UK. So we're both Karen and I, Miss Booth and I, are really passionate about that, as is our team, so that you won't be alone. We will help you make those contacts. You don't just have to be in the favoured sort of positions or have the tap on the shoulder. We're keen to give everybody a tap on the shoulder. And a few more questions have come in now. So somebody's asked about whether your audits have to be in cardiothoracic surgery. I think it's nice that they are, but they don't have to be. An audit is as valuable. When you do an audit, you're learning all sorts of things about clinical governance and quality improvement. Clearly, that can be in any field, and those skills, having performed an audit, are transferable.
Yeah, the application is just looking for all these different skills. Do you have leadership qualities? Do you understand audit and quality improvement? Do you understand research? Can you set up a teaching program? Do you know how to teach different styles of learners? That's what all this application form is, sort of looking at a well-rounded person. So again, it doesn't have to be specialty specific, but there is a part of the application that is looking for commitment to the specialty.
Yeah. And another question come through anonymously. Is it okay if you're not in the top 10% of your medical school? Absolutely.
Absolutely. I wasn't. I was average.
I don't think I was either. It was like I went to school a little while ago, and I was lucky enough my ambition was to go to Guy's Hospital, but ended up applying to Oxford, and I was accepted to read medicine at Somerville. And I'm pretty certain that I wasn't in the top 10% of that. So. No.
Someone said to me at medical school, which I found really helpful, is getting into medical school, you're sort of the top sort of 1 to 10% of the country already. You're amongst a group of very intelligent individuals. It's very difficult to be top 10% of those. So just if you're average, that's absolutely fine.
And then also the question goes on to say, can you give us a top few top tips to be in the top 10%. Well, that's really up to you to follow, do your revision and do all your SSCPs, etc. And and now a different question slightly. How important is it to have a foundation job in cardiothoracics? Well, it's nice if you get them. There are very few, aren't there?
Very few.
F2s. Swansea happens to be. In Wales, we have uncoupled foundation trainees who apply separately for F1 and your F2 year. And certainly in Swansea, we have an F2. I think maybe Manchester. There are very few and far between. So clearly the majority of people aren't going to have that on their CV. But obviously when you get into CT, core training, people have more opportunities. So it's not the be all and end all, but if you have the opportunity, then that's great. So but don't despair if you haven't, because you can do a lot of the other things that will give you the points for your CV.
And there's so much transferable skills to be gleaned from doing other surgical specialties, plastics, general surgery. There's so many transferable skills. So if you don't get a specialty job in cardiothoracics, as long as you have surgical posts, if you're interested in surgical, I'd advise you to do that. Think about whether or not you want to move deanery to choose cardiothoracics jobs. But I didn't have a foundation job in cardiothoracics and just a lot of general surgical experience and orthopedics. But I caught up. As long as you're committed to training and learning, you'll get there.
And another question about portfolios and how to enhance them. And I think we've talked about presentations and getting experience. Maybe, as I said, I really recommend that you join ASIC. They don't pay me to say that. One of the things is that leadership comes in many forms. You might be really sporty. You might be, you might run the social side of your local karate club, whatever. All of these things, if you organise an event, it doesn't have to be a cardiothoracic event. If you're involved in a sports team, all of these demonstrate that you have skills in both communication, teamwork, leadership. And the other thing I've sort of learned over the years is, and this is not particularly in terms of cardiothoracic, but when you're specifically, but different people have different styles of promoting what they do. And I find that there can be a dichotomy, and especially now that a lot of our stuff is not necessarily cardiothoracics, but say for core training, a lot of things go on the application form because of COVID and not having many face-to-face events. You really do have to, there's a balance between selling yourself, not underselling yourself without overdoing it. And I very much see two groups of people, and a group of people who are very factual about what they do and almost undersell it or don't want to blow their own trumpet, and people who have a whole orchestra of trumpets. And clearly there's a balance in between of how you present yourself. So don't hide your light under a bushel, but equally don't bullshit, because it's just really it's not very conducive to anybody. Right, I think, sorry I swore just there, but I think on that note, so make the most of your opportunities and think creatively about all the skills that you have gained. You might be a student rep in your university you may be a year cohort lead, you might be a BMA rep, you might be involved in voluntary work. All of these show teamwork, communication skills, leadership skills, dedication, compassion, and those need to be somewhere on your application. So on that note, I think we will end this session, and I think you all have a link to the, do we stay in this room for University Challenge team, or do we have another link to go to? I think we stay here, so I'm going to hand over now to, thank you very much, Charlotte. I really appreciate your time and your insights into training, getting a training number. And I hope to see you soon.
Thank you for having me. Thank you.
Very welcome. And now I'm delighted to introduce our president. I shall doff my cap to him, Mr. Simon Kendall, who is going to be the Jeremy Paxman of our next 45 minutes. And I'm introducing Kirsty, one of our new student committee members, and together they are going to run our first virtual university challenge. Thanks to Karen and her team for putting together some questions. And I'm going to hand over to Kirsty to run the show. We'll be here in the background and try not to interfere. And I don't think there's any music around, so you can all relax. So, okay.
Thanks, Farah. Can you hear me, by the way?
We can hear you very well. And
Good.
Kirsty?
Brill, can you hear me as well?
Perfect.
Okay, great. Well, like Professor Batty said, my name's Kirsty. I am on the new SETS student committee, and I'm the mentorship officer this year. And I'm joined by Mr. Simon Kendall, who's a cardiac surgeon at James Cook, and he's also the president of SETS, and he's kindly agreed to host our university challenge today. So before we start, I just wanted to kind of go over how the challenge will work. So there'll be 3 rounds of 10 questions. We'll have a short kind of 30 second.
I'm sorry, Kirsty, you're cutting out, so I don't know if you can hear me. Can we everyone mute if they're not speaking, please? Can everyone mute if they're not speaking? And Kirsty, could you go through that again, please?
Oh dear, Kirsty's gone altogether.
Technical.
Sorry.
Oh,
Kirsty,
back.
you're back. Fantastic.
I'm back. Sorry. I don't know how long we can go through this pandemic and I will still have Wi-Fi issues. So, like I was saying, there will be 3 rounds of 10 questions. After which the winner of the £300 will be announced, which is very exciting. Do we know if there's a raise hand function, or does anyone know?
We're just getting a message from our host, and I will read it out when it comes through. And if there's, I'm not sure. So I think we have to physically raise hands, which is good because we'll get a bit of exercise.
Okay.
We're all going to be sitting down. So raising hands, and I guess you're going to just go through again the format and the teams, etc. So over to you, Kirsty.
Yes, great. Okay, so in the absence of a button to press, if you do raise your hand and you wait, and the first person to raise their hand will be asked to answer the question. If you get the question wrong, it will then be passed over to the next team. So you kind of want to be semi-confident that you know the answer. And then if no one gets it right, we'll just move on to the next question. So without further ado, let's get to know our teams. So first we have Scalpel from Manchester, and on their team they have Asmita, who's a 3rd year student, and she enjoys writing poems, swimming and yoga. We have Malvika, a 3rd year student who is a blue belt in Chinese kickboxing. And then we have Nadine, an international student from Egypt who loves archery and playing guitar. And finally, we have Aisha, a 3rd year student who's originally from the USA, who is a keen oil painter. And then next up, I love the punny team name on this one, from Leeds. We have Leading the Way. And we have Amelia, who's our medical science student, and she's the SETS regional events officer, a keen triathlete and rower. We have Javeria, our widening access officer, and she's in 3rd year. And a fun fact about her is that she used to attend postmortems in her free time in 1st year. Then we have Robin, a 3rd year medical student, and finally we have Faye, who is a 2nd year student also from Leeds. So now that we've met our contestants, I will hand over to Mr. Kendall, who can start with the questions.
Okay, good morning, everyone. We've got 3 rounds of 10 questions, so we'll head into the round 10, or the first 10 questions. So, first question. In the anatomy of the conduction system of the heart, the sinus node is found on the junction of the SVC and the right atrium. But when the conduction feeds across the right atrium, what is the next conduction node?
I think that was Robin.
Right, Robin?
Yeah, so the atrioventricular node.
That is correct. Right, next question. How many lobes are there in total in the right and left lung combined?
Nadine?
5.
Correct. Next question, number 3. The ECG is a recording of electrical activity within the heart. What physiological action does the P wave denote?
That was Nadine again.
Depolarization of the atrium.
Oh, correct. Can I just check who's keeping the score?
That's me.
Okay, well done. Because it would be bad to get to the end and not know the score here. Right, Marfan syndrome is a genetic condition which affects which vascular organ in the body?
Robin?
The heart.
No, next.
Okay, so that will pass on to Manchester.
Aisha, you Manchester? Yep.
Aorta.
Aorta is correct. Fantastic. Good. Question 5. What is the name of the vein in the leg most commonly used in the coronary bypass operation?
That was Nadine from Manchester.
Saffon's vein.
Correct. Number 6. Tissue histology of the 2 most common forms of lung cancer are small cell cancer and which other cell type?
Aisha?
Squamous.
No, that's not correct.
Okay, so that will pass over to Leeds. Amelia?
Can you hear me? I can't tell if my microphone's on or not.
Yeah, we can hear you.
Yes.
Non-small cell lung cancer.
Non-small cell lung cancer. Correct answer. Fantastic. Good. Number 7. An endobronchial blocker causes an obstruction to where in the body? An endobronchial blocker causes an obstruction.
Amelia?
The bronchioles?
Yep, airway or bronchioles, that's correct. Number 8, cardiogenic shock is defined by a systolic blood pressure less than how many millimeters of mercury?
Nadine?
Systolic less than 90.
Correct. I'm really impressed because I didn't know that. That's awful. Farah, did you know that?
Of course I did, Mr. President.
Number 9, the Ross operation describes a surgical valve replacement procedure for which valve in the heart?
Amelia?
So the aortic valve is replaced with the patient's own pulmonary valve.
Yeah, and you don't get a bonus point for the pulmonary valve bit. It's just 1 point. Nice try, though, Amelia. And the 10th question in this first round. Cardioplegia is a solution given to stop the heart in open heart surgery. Which electrolyte is most effective to induce diastolic arrest?
That was Javaria.
Potassium.
That's correct. Fantastic. So that's the end of the first round. Not only am I impressed by the answers, I'm impressed that everyone's got their hands up for most of them. So this is you're far too good to be students. Are you sure you haven't already qualified or something? Okay. Right. Scores in the doors, Kirsty.
So currently it's neck and neck with both teams with 5 points. So it's all to play for.
Well, our audience will think this is rigged. I'm really impressed. We've got people from Pakistan, from Africa, from India. It is quite remarkable how many people are listening in this morning. So superb. And I think Farah may have said it at the start, but this Pat McGee session is named after one of our former presidents, and he was a remarkable man, great surgeon, but his talent for knowing everybody's name, your partner's name, your children's name, he was just a wonderful gentleman and man. And we started inviting medical students to the annual meeting just to help out carry the microphones, and then we had a poster competition. And I think he would be absolutely delighted to see so much engagement and enthusiasm. So it's a credit to his name that you're all here. So thank you very much. Right, Kirsty, should we go on with the next round?
Yes, can I just check? Is everyone... Faye, I know you were having trouble with your connection. Is it slightly better now?
You're good. You're fluent. Is everyone... Are my questions audible?
Yeah, I think everyone's rejoined. I just know that some people were cutting out, so I think everyone's back now.
Okay, cool. Right.
Yeah, second round.
Second round, roll the drums. Here we go. Round 2, number 1. A paravertebral catheter is a method of analgesia used in thoracic surgery and is placed under the pleura beside which anatomical structures?
Robin?
Can't hear you.
Robin, you cut out just at the wrong time.
Sorry, the vertebrae.
Yep, you're right. It's the ribs or spine. So yeah, that's the right answer. Thank you. Number 2, obstructive lung disease is classified by the ratio of FEV1 to FVC and has a cutoff value of what? Is it less than 70% or greater than 70%?
I think that was Javaria who answered before you'd even finished the question.
Okay.
I'm going to less than.
Yep, correct. Well done. Guys, just have you seen that film where he University Challenge, and then he cheats and sees the question and he says the question before they've even asked the question? It's just a stunning film, great film. I'll remember it eventually. Right, here we go. Number 3, the pulmonary artery carries blood from the right ventricle to which structure?
Nadine?
To the lungs. To the lungs.
Correct, that is correct. 1 point. Question 4. The coronary circulation supplies the heart is made up of primarily of how many blood vessels?
Malvika?
2 coronary arteries.
Yep, 2 coronary arteries is the right answer. Good answer. Number 5, the Stanford classification system for aortic dissection is split into 2 types, A and...
Nadine?
A and B.
Yep, correct. A and B. Number 6, stenting of a coronary artery is called PCI. What does PCI stand for?
Nadine again.
Primary coronary intervention.
No, not quite. I'm afraid I can't give that.
Javaria?
Percutaneous coronary intervention.
It is indeed. If they come in with a heart attack, it's primary percutaneous intervention, PPCI. So, yeah. Okay, question 7. What does the term MDT stand for?
Robin?
Multidisciplinary team.
Yeah, I think I will give you that. The answer I've got is multidisciplinary meeting, which is, of course, MDM, but MDT is multidisciplinary team. So I think we'll give you that is the right answer. Question 8. An interrupted aortic arch describes a disconnection between which 2 aortic structures?
Amelia?
Ascending and descending.
Yeah, absolutely. Well done. Amelia, did you write these questions? Just checking.
No, I'm not even a medical student yet, so definitely not.
That makes me even more humble. Right, question 9. The first heart transplant was famously performed by which surgeon?
Javaria?
Christian Bernard.
Yep, that is correct. So he was a bit of a forger, really, Christian Bernard, because he worked with Norman Shumway in San Francisco, in Stanford, and he learned all the techniques from the Americans and from Norman Shumway, took all their ideas, flew back to South Africa, and then performed the first heart transplant and got all the glory, and that's why you know his name in this quiz. And there was this big burst of heart transplantation, and sadly, the mortality was really high because of early rejection. And Norman Shumway went away, worked really hard at working out how to prevent rejection and biopsy the heart, and he ended up being successful. And I had the pleasure of working with Norman. He was a fantastic man, absolutely amazing teacher. So this is his quote. He said, "The worst thing that ever happened to me was not doing the first heart transplant. And the best thing that ever happened to me was not doing the first heart transplant." So, great man. And his daughter's a cardiac surgeon as well. Anyway, I digress. I'm sorry. Question 10. In statistics, the term median in a group of values is a description of what?
Amelia?
The middle value.
The middle value is spot on. Right, that is the end of round 2. It seemed to go really quickly. Thank you very much. Kirsty, how long do you need to do the adding up?
About 2 seconds.
2 seconds.
Okay, so scores on the doors. Leeds are on 12 points in total and Manchester on 8. So still very close. So the last round is going to be very telling.
Good. And it's very easy to see which team is which by the smiles. So that was good. So where are all the guys? I mean, did you just exclude them from the teams? Is this taking equality diversity just to a new level?
Oh no, Simon, we're not going to the start one. What about the poor men? No, this was strictly on whoever wanted to be on it. So it was all chosen very fairly, and
fantastic.
The girls are on top. So.
Right. Very good. Right. Are we all set for round 3, Kirsty?
Yeah, I think we're good to go.
Okay, excellent. Right, round 3, 10 more questions. 12-8. Let's see if we can catch up. In congenital surgery, what does the term ASD stand for?
Robin?
Atrial septal defect?
Correct, that's right. Robin, do you cut out just so you can Google it in that time? Is that
No, I think my computer lags when I try and turn the microphone on and off.
Yeah, Robin, so next time put your hands up so we can check that you're not typing at the same time. Okay, cool. Right, question 2. In heart failure medicine, an LVAD is a device used as an alternative to a heart transplant. What does LVAD stand for? LVAD.
Nadine, although I will call you out on the hesitancy there that you were like, I'm going to put my hand up, but I don't know what the question is yet.
Actually, I think I'm going to Kirsty. I might take over from that. I think I saw Malvita's hand first. So can we pass it on to Malvita, please?
Left ventricular assist device.
Correct. Excellent. 1 point. Question 3. What immunosuppression medication caused the breakthrough in transplantation in 1983, allowing patients to survive for longer?
And I think that was Malvita again.
Asmita?
Okay, Asmita.
Cyclosporin.
Have we got the answer? Who's answering?
Cyclosporin.
Cyclosporin, I think that was correct. Yeah.
Good, sorry, it cut out there. I didn't hear it. Cyclosporin.
Can I just check who answered that?
Asmita answered it.
Okay.
Can I ask, when I did transplantation, it was CYCLO, cyclo, as in bicycle. But the spelling in the answer sheet is CICLO. They changed the spelling of it. Still CY. Thank you. Just checking. Good. Moving on. Question 4. In thoracoscopic lung surgery, what does VAT stand for?
Robin?
Video-assisted thoracoscopic surgery.
Yeah, spot on. 1 point. Okay, question 5. Tissue valve replacements made from pericardium commonly come from which animal?
Robin?
Porcine?
That is not the right answer. Over to the other team.
So pass to Manchester. Malvika?
Bovine.
Yep, it's the bovine or the cow. So the tissue valves from the pig are used as tissue valves, but the pericardium comes from cows, from calves. And of course, you've got a big pericardial sac, so you can make quite a few valves from one pericardial sac, whereas I think only 3% of pig valves pass all the quality markers to be used. Right, we've got 5 questions left. Let's see how we go. A pneumothorax describes a condition in which air has entered which cavity in the body?
Javaria?
Pleura.
That's not a cavity. I'm not taking that. Which cavity is it?
Okay.
So that'll pass over to Manchester. Aisha?
The pleural cavity.
It's just a bit quiet. Say that again.
The pleural cavity.
Yep, that's correct. 1 point. Question 7. Cardiac output is defined by heart rate multiplied by what?
Oh, I don't know who was first there. I think it was Nadine.
Stroke volume.
Yep, correct. 1 point. Question 8. To perform open heart surgery, a perfusion machine called CPB is called... What does CBP stand for? CPB stand for?
Amelia?
Cardiopulmonary bypass.
Correct. Question 9. Which artery is the blood supply to the hand is found in the forearm?
Nadine?
Radial artery.
Correct. It's really interesting. So I think it's the radial artery and the ulnar artery, but only the radial artery is put in the answers, but we would have taken either. And the last question. In what year did the first successful heart operation using a bypass machine take place with John Gibbon? Was it 1953 or 1943?
Robin?
1953.
Correct. And that's the end of the questions. Thank you very much, everyone. An impressive array of knowledge, not only because of the people who've answered the questions, but everyone else who's putting their hands up. So thank you. Roll the drums.
This is very, very close.
Oh,
there are 2 points in it.
Yep.
But the winners of the inaugural University Challenge are Leeds. Congratulations.
Hey. So good. As I said, it's easy to spot the Leeds team because they're a big cheesy grins. So thank you very much. Commiserations with the losers from Manchester. Hard luck. And Farah, remind us what the prize is.
The prize is actually £300, so it's no mean feat to have won this first University Challenge. Thank you for all of you participating. Next year, we are hoping that we will be doing this live, and as this was the first go at it, we'll actually hope to have some rounds through the months leading up to the March meeting next year, so that it really will be a very inclusive University Challenge, and we'll find out. And I think really the other bit is that we need to make the questions harder because you are all far too good, and we'll get some good buzzer noises as well, so that we're not just relying on hands. But well done to all of you. Thank you for putting yourselves up for this. Very close indeed. So just some people were quick at raising their hands than others. So congratulations, Leeds. Commiserations, Manchester. Well done, Mr. Kendall, on doing your best Jeremy Paxman impression.
No, I wasn't sarcastic enough. Because so Farah probably said this, but so we had the pleasure of meeting in Oxford, and I was doing my first case in Oxford as a senior registrar, and I was terrified. And poor Farah was picked on to be the senior house officer to take the vein and help me with this operation, and we've just been bonded ever since. And she knows that I can be a really good sarcastic Jeremy Paxman, and I've learned to be a better man, I hope, over the years. So Farah, thank you.
Excellent. I get the prize for making you a better man. I think I'll take that. So.
Yeah. Thank you.
Congratulations, Lee. Thank you, Simon, for running the show. Thank you, Kirsty, for keeping everyone in check. And I think this means that we actually have an early lunch. But I think while we have the president, and as we do have some time, because we rattled through those questions, I wonder whether any of the participants, as you know, we've got a big international audience. Would anybody like to ask any questions from the audience, or in fact from the panel? We've got Leeds and Manchester students. Would you like to ask anything of the president? Polite, of course. Malvika.
Why did you choose Cardiothoracics?
I was a lazy medical student. It was really interesting hearing Charlotte about being in that top 10% thing. I was definitely in the bottom 5%. And out of the whole year, there were 2 biochemistry exams in the first year, and I was the only one to fail both of them out of the whole lot. And I just did medical school because it was just the best of fun. Organising rugby teams, doing Christmas concerts, rag weeks, and then you have to pass finals. And I didn't really want to work hard, and I was really scared of surgery because it was such hard work. And surgeons were odd because they didn't have lunch breaks and they started early and finished late, and I didn't fancy that. But then I thought, well, actually, I wouldn't mind doing orthopedics. So I was quite impressed by orthopedics. I nearly joined the army to become an officer to do orthopedics, but there wasn't enough career progression, so I stuck with the NHS. And I was all set to do orthopedics. And then on my 3-year rotation, there was cardiothoracic surgery at Killingbeck Hospital in Leeds. And in August, in '86, I did a 1-in-1 for the whole of August because the other registrar was away. So I lived in the hospital for a whole month. And in no time at all, I was doing thoracotomies, doing lung resections, opening up chests, taking mammaries, putting patients on bypass. And I was on intensive care looking after adults and children. And it was phenomenal. It was absolutely, I could not believe the technical challenge of surgery, the pharmaceutical interventions in the ITU. And what I couldn't get over was when patients came back to clinic, they were so grateful and they were better. And sadly, what I'll share with you is it revealed that I was quite a shallow person in that I like quick fixes and quick rewards. So whereas a GP or a rheumatologist has a long journey with the patient, the surgeon's quite a sort of shallow intervention in comparison. And that was it. It was just the love of being in theatre with the theatre team, with your colleagues. And, you know, I wish now I could go back and do it all over again because it's been such a privilege and such fun. And I have imposter syndrome. So I think you guys are going to find me out at some point, but I may just get through this without being found out.
Thank you, Simon, and thanks for that question. May I ask you a question, Simon?
This will be rude. Go on.
No, it's out of genuine interest. We've heard Joseph George do a very eloquent presentation on anatomy, congenital, and his love for congenital. And we have, and a little bit, we touched on work-life balance. And you've talked about spending a whole month in a hospital, essentially. So I'd like to ask you, and often as Chair of Women in Surgery, we've got a Q&A session, often the female surgeons, the women surgeons, are asked, how did you manage? You know, and we're often asked, can you have children? Can you do this? How do you manage? So I'd like to ask you, how did you manage when, I don't know if you have children, because I've never really asked. I'm sort of assuming you did, but you mustn't.
2 children, yeah.
And so how did you navigate your early career when you were training and working all these hours? How did you and your family, if it's not too obtrusive, but it's something that we answer day in, day out, or asked, how did you manage your juggle the childcare, etc., parents' evenings, runs, etc.? How did that work for you?
Yeah,
and I plan to ask that to a lot of our speakers today.
Yeah, I'm talking this afternoon about the change in our specialty, and it was a very different era then, and you were expected to commit to your surgical specialty, and your partner accepted that was the deal. And I've just told you about transplantation, and you know I did that at Papworth. And it was horrendous. We would go flying off on donor runs. We'd be up all night. We'd then transplant. We'd then operate the next day. And Sue, my wife, just had an awful time because she didn't know when I'd be home, and she didn't know when I'd be called out. And we couldn't commit at weekends to everything. It was very difficult to book our holidays. And it's tough. It is really tough. My wife has put up with my profession. And it's awful. And I think in answer, I think it's about time management. Now, when I was in Oxford for a year, we rented a house near the hospital, and my commitment was to be home at 6 o'clock to do bath time, because by that time, not bathing my wife, I hasten to add. So that was my children. And you know, it was very important to get your time management right and do your bit. And I really like the modern, and the difference now is at that time, the surgeon themselves was responsible for their patients, and you were sort of meant to be available all the time. And what is changing, and the difference now, is that it's a team of surgeons and you're looking after each other's patients, and you should trust each other. So you can go home for the weekend, you can go on holiday, you can go home at night, and you know your colleagues will look after your patients, and that achieves the work-life balance. So time management's really important. Family is the most important thing. But at the same time, Farah, I would say the more you put into this lovely job that we're lucky to do, the more you get out of it, and you've got to keep that balance. It's it is tough to keep that balance right, and there's lots of role models to work out how to do it, which suits you.
Thanks very much, Simon. Appreciate you sharing that insight. And I was a bit worried when you started talking about bathing your wife. I thought I might have to cut your microphone, but I'm glad you pulled it back. There is one more question, but I think you're probably going to touch on it later, because I know you're coming back kindly and sharing your thoughts about the future of cardiothoracic surgery in the next session. So I think we'll leave questions on that topic until later. And I think you're going to join us for the Q&A at the end of that as well. Yeah, that's great. So, well, I think if there are no other questions from either the panel, you've got the president, you've got him here, you've got his undivided attention, but he is coming back again this afternoon. So I think that means that we can have an early break for lunch, and we'll see you back here in the afternoon. So thank you to all, to our two inaugural university panels. Thank you to all the participants from across the world. Go away, have some lunch or breakfast, depending on your time zone, and or supper, and then we'll see you again shortly. Thanks very much.
Thanks, Farah. Thank you.
Bye-bye.